The parathyroid glands are small, paired, yellow-brown glands. All four glands are supplied medially by the inferior thyroid artery. The superior glands are derived from the fourth branchial pouch, along with the lateral thyroid tissue, while the inferior glands are derived from the third branchial pouch, along with the thymus. Superior glands are most commonly located on the posterior lateral aspect of the superior pole, and variants tend to be posterior, such as in the tracheoesophageal groove, retroesophageal space, or within the carotid sheath. The superior gland is dorsal and lateral to the recurrent laryngeal nerve. The inferior glands are most commonly at the lower aspect of the inferior thyroid pole, but travel a greater distance and can be more variable, with variants most commonly seen in the anterior mediastinum within the thymus. The gland is ventral and medial to the recurrent laryngeal nerve. Parathyroid hormone, or PTH, is released from chief cells and regulates calcium homeostasis through three mechanisms. PTH binds to osteoblasts and indirectly stimulates osteoclasts, enhancing bone resorption and release of calcium and phosphate. In the kidney, PTH acts as the distal tubules to enhance calcium reabsorption and inhibit proximal phosphate reabsorption. PTH also stimulates the conversion of 25-hydroxyvitamin D to active 1,25-hydroxyvitamin D, which stimulates calcium uptake in the intestine. The net effect is an elevated calcium and decreased phosphate level. Patients can present with symptoms of hypercalcemia, including the following: kidney stones and nephrocalcinosis, bone pain, osteopenia or osteoporosis and pathologic fractures, abdominal pain, nausea and vomiting, constipation and polyuria, fatigue, muscle weakness, poor concentration, and depression. Primary hyperparathyroidism occurs when one or more parathyroid glands function abnormally to secrete inappropriate levels of PTH. The most common cause is a single adenoma, followed by hyperplasia, double adenomas, and rarely parathyroid cancer. Diagnosis is made with an elevated serum calcium and PTH. A 24-hour urinary calcium will distinguish between hyperparathyroidism and familial hypocalciuric hypercalcemia. A sestamibi scan combined with SPECT increases sensitivity for localization of adenomas. Surgical parathyroidectomy is indicated for all symptomatic patients as well as asymptomatic patients who meet the listed criteria for resection.